Brett and Russ, welcome to the SABM podcast.
Thank you. Thank you, Scott.
Yeah, well, hey, it's been a pleasure getting to know you guys over the last few months and watching the investor group pitches and you've done a great job and it's really been exciting just to learn about the company that you're building, Compassion Neuroscience, and maybe just to kick things off, Brett, if you want to take the lead and just provide an introduction and share what you guys are up to.
Sure. So I'm Bret Petkus. This is my partner, Russ Toll. We're both West Point grads. He's better looking and I'm a lot older. Right. So I graduated in 91, Ranger School, Airborne School, served in the Army 5 years, got out. Then I got into healthcare, med devices with J&J, then got into obesity treatment, surgical treatment for obesity and medical treatment for obesity. A lot of shame in that space. And then was running some clinics and otherwise and building some companies up. And then I was going through my VA record and I noticed, wow, spring ball of my senior year, I was admitted to Keller Hospital for a TBI. And I'm like, what in the world? I have no memory of this for all the funny part of that and sad part of it. I called my roommate, Brian Fitzgerald. I'm like, Brian, do you remember me getting admitted to Keller Hospital? And he's like, yeah. And then the next day you were fine. You were right back at practice. I'm like, oh, good. So, look, that was 30 plus years ago. I discovered this about 2 years ago. I'm like, I'm just going to reach out in DFW, see if I can find a West Point grad that's a neuroscientist to see, is there anything I need to worry about on a go forward basis? And that's when I reached out to Russ. And Russ, we'd love to hear your story.
Yeah, I'm Russ Toll. I'm an '05 guy. And when our class went straight into Iraq and Afghanistan, and that was my story too. Went to Fort Hood, went armor, tanks and infantry combination. Went over to Iraq, did about a 14-month tour over there in Bakuba, and this was '06 to '08, so it was during the surge. It was very intense. About a third of my guys got the Purple Heart. I got blown up a bunch. Everyone did. And so I got to see, the inside of Army medicine, how we do caches, how we do evac, and kind of lived that firsthand. And we all made it back about December of '07. And then I got tapped to be the casualty officer for the next deployment. So I got more with Army medicine, not only from the notification side of knocking on doors and giving that medical center and checking on our very after I was doing that, if you're walking up and down the hallways of Walter Reed in 2009, you're going to remember what you see and hear and smell. And that was kind of my inflection point where, I saw how incredible our doctors were. Our nurses were and how lacking. Complain about it, write your congressman or do something about it. And I went and talked to the colonel and said, boss, I'm a halfway decent engineer. If a miracle happens and I get into grad school, can I pretty please refred and go to the reserves? And one thing led to another, and I wound up at Stanford. So started Stanford in 2010, worked towards a PhD in bioengineering / neuroscience. Kind of got really good at EEG, MRI, and this new thing called TMS that we developed. And after Stanford, right before COVID, 2019, went to UT Southwestern in Dallas to be a research professor doing more of these studies on the clinical trial side. And it was about that time frame that I got a LinkedIn message from this guy named Brett. Said he was an old grad, 91 dude, and wanted to come on by.
All right. Yeah, and tell us what happened from there. So, Brett, it sounds like you had a kind of like a previous issue that you wanted to look into and to see if there was if you were okay, right? And then, but it sounds like the two of you guys came together on a new product that you're offering to help folks, and yeah, would love to
Yeah,
kind of see how things have evolved from there.
you nailed it, Scott. So what was wild about it is I love to geek out on med devices and med tech. And so I call Russ, we're on the phone, and he goes, well, Brett, so good. Let's connect. I'd love to talk to you more about this. I just opened up a clinic in Southlake. And I'm like, in Southlake? I live in Southlake. Are you kidding me? He goes, no. So we got to the clinic and we had a chance to connect and talk about what I was doing, and seems like, hey, everything's okay there. But what more importantly, Russ showed me what he was doing, and I was blown away because, Scott, one of the things I'm in the military community, right? But I never served in combat. I was never blown up. I also never had to knock on a door of a gold star. And one of the things that I've learned is that, losing a soldier or sailor, I thought would be equivalent to knocking on a door and giving notice to a family. It's not even close. It's probably 10, 20 times worse. I've had Navy SEALs come in and tell me, Bret, I'd rather lose 20 guys than knock on another door. So the gravity of the gold star and the impact was really, really moving. And I learned that from Russ. Then number two is he showed me this new technology. So what I didn't realize is when somebody's depressed, their neurons have stopped firing. And when they're anxious or have PTS, they're overfiring. Now, traditionally, we throw meds at those folks, right? Docs just give meds and it's, let's see what happens, come back and see me. We know about polypharmacy that's taken place in the VA and otherwise. And what Russ was doing was measuring. He was measuring the brain. He was creating a baseline and then identifying targets for TMS. TMS is transcranial magnetic stimulation. So it's using a device. It's kind of like if your arm's broken, what are you going to do to get it fixed, right? Well, you got to measure it. You need to go get an x-ray and find out where is it broken? What do we need to do to fix that compound fracture? And so it's the same thing here. So I learned about TMS, which is the device to treat. The FDA approved this about 18 years ago, which is young for a medical device. And why a lot of us haven't heard about TMS is because the outcomes haven't been that good. They've been almost equivalent to what's going on with the antidepressants. And what I was really impressed with Russ on was he was improving the outcomes. He was doing it because he was personalizing the TMS. So instead of going after a traditional area, the DLPFC, which is a part in the brain, he was measuring using EEG. He developed software called Halo, holographic algorithm for localization and optimization. So the EEG data goes into Halo, and that allows us to create a baseline and show a patient, here's what's going on. Here are where the dysregulated networks are, and here are the places that we want to treat. This software goes then to our psychiatrist who visits with a patient, and they identify the treatment parameters. And Scott, I'll tell you that the outcomes have been unbelievable. The other key piece is two stories that I'd love to share in this journey with Russ. One was I'm on the way back to the Army football golf outing in July last year. It's June. I'm talking to Garth Eastat. Garth was a senior when I was a plebe. We were both in E2, both Brewdogs, go Brewdogs. And I couldn't wait to see him. I'd golfed with him and his son in the past. And next thing I know, I find out that he chewed on a bullet. And Scott, I came back to the clinic because Russ and I were starting to build this together. And I was really pissed off. I was angry at Garth for abandoning his family. And I didn't know what to do with it. It hit me so hard. It was the first time I'd had suicide hit me in the face this hard. And Russ kindly reminded me, Bret, remember what I told you. And, we're talking about a Stanford neuroscientist. I'm like, what? He goes, remember, his cockpit got hijacked. And I'm like, oh my gosh. And it gave me so much relief, Scott, to know that Garth's cockpit had been hijacked. And in fact, I was able to share that with a bunch of the other guys that were also distressed because we lost a brother, right? And then I looked at Russ and I'm like, well, we're a couple of Army guys. We need to breach these cockpits, and how do you breach a door? You got to measure it. You got to know if it's wood, is it steel, how thick is it? And that's what Russ developed with this software. We're measuring the organ that we're treating, right? And that's what I'm really excited about of what we're doing here at Compassion Neurohealth. And we're seeing the outcomes with these patients. Remarkably enough, at the end of that golf outing, Scott, and this is what got me to be all in on this, a buddy of mine said, hey, go look at your Facebook page. And I'm not a big social media guy, but I go look at it and I see that Judy Bourne had just posted, and we have permission to share this story. Judy had just posted that their daughter had passed. And so Brent Bourne went to prep school with me, played football with me. We're buds. So I called Brent while I was still at this golf outing, and I'm like, buddy, what happened? And I mean, we're both bawling on the phone, Scott. And I finally, really understood what that loss, that star family loss, felt like. It was my first time really experiencing talking to a parent who'd lost a child. And Brent told me he and Judy were going up into the mountains for a week. They'd come back and talk to us. So he came back. We talked a week later, and I'm like, "How you doing?" He's like, "Not good. This has been hard stuff." And he's like, "Brett, I've been depressed for a couple of years. It's driving me nuts." Nope. The doctor, they don't measure anything. They just throw meds at you. You take a survey, and I'm like, "Brent, we're measuring." He's like, "What?" I'm like, "Yeah, we're measuring." He goes, "What are you talking about?" I'm like, "I got to introduce you to Russ and what we're doing in our clinic." And so Brent went to his doctor, who didn't even know what TMS was, right? But we shared him with what we're doing. He decided just to do the self-pay option. He flew in for 10 days, and we treated him, Scott. And at the beginning of this, he had a PHQ-9. PHQ-9 is a survey that's used. Psychiatrists use it, but so does primary care, and so does family practice or internal medicine. It's a survey to determine if you're depressed. And it's just asking you 9 questions, 0 to 3. So this is what insurance uses to validate that somebody's depressed, or even getting meds, or taking TMS. And Brent scored a 25. Is that yes. He scored a 25 out of 27. After 10 days of treatment, these meds hadn't been working with him. He's on a couple of antidepressants. He scores a 25 out of 27. He's down to a 6. Now, what's amazing about this, Scott, is we showed him, wow, you're really made massive progress, but you're not done. We need you to come back. We need probably another 3 or 4 treatments. And TMS is interesting, Scott, because it's like rehabbing your shoulder, right? Think about physical rehab. We're rehabbing the brain. We're not doing surgery. This is a magnet that's stimulating the neurons in some areas, and then it's slowing the neurons down in other areas. I had Brent over to the house, and I'm still learning and geeking out on this stuff. And I'm like, "Well, how you doing, buddy? Let's have some pizza and talk." He goes, "Brett, I haven't slept like this in years." I'm like, "Wow, that's impressive." And we know sleep plays a role. It's an early indicator for mental health. What else is going on? He goes, "Finally, I can shut him down." I'm like, "Shut what down? What are you talking about?" "The negative thoughts." I'm like, "What? What do you mean? You didn't even talk about these negative thoughts." I'm like, I know. He's like, "I know. I didn't even know how to express it. But Brett, I was overwhelmed with negative thoughts, and they're gone. I can get rid of them." And Scott, that blew me away. That's where I'm like, holy cow. Wow, what an amazing solution that my partners developed with the software that's showing. I'm showing Brent afterwards, even his brain and the improvement. And Russ, could you share a bit about the targeting? Like, what did you find when you first did that Halo?
Yeah, so when we're talking about Halo, we're talking about EEG, which is a really simple cap that just goes on your head. We take a 10-minute recording, and that's all we need. With that recording, I can do a source localization process that's similar to how you find out where an earthquake came from. Whenever they say the epicenter of an earthquake was at this point, well, they get that information from a bunch of different seismometers on the surface. They measure the pressure wave, they do the math, and they can backtrack and say it came from here. That's effectively what we do with EEG. With those electrodes, we can record that electrical activity, we can backtrack it, and I can say this signal came from here. And it's the basis of a connectivity map that answers the question, which regions are connected to which other regions and which. And once you have that map, you'll have areas in red, you'll have areas in blue that describe too much connectivity or too little. And when I did Brent's, I remember texting Brett and saying, make sure you know what this guy is. This is one of the hardest cases I've seen in a hot minute. And what made that case so hard is his posterior cingulate, this region in the back of the brain, was massively underconnected as compared to the global norm. And why that's important is that the cookie cutter target for TMS is a target called F3, which is at the front left of the brain, right behind your left eyebrow. If Brent had gone in for standard TMS, which is done by literally putting a swim cap on you, taking out a physical tape measure, taking a few measurements of landmarks on the face, drawing an X with a Sharpie, and lining up the coil by eye. That's the current standard of care. If they had done that with Brent, they would have missed. They would have, in artillery terms, shot outside the box. Uh, what we were able to get with that Halo EEG is knowing that F3 is not the target that's going to respond. It's PZ is on the completely different side of the head. We're midline in the back. That's where we need to line the coil up. And so once you have that information, you can dial in the parameters right, and you can keep using that EEG and not only answer the question at the start of where do you want to shoot, you can answer the question midway of did we have effects on target, and keep answering that question until you're sure that you bracketed it in and you got the connectivity right.
What causes this to happen in a person's brain? Are some people born like this? Is it an experience that they have?
The
What?
genetics do contribute to it and predispose you to a number of these issues, but what it really is learning. It's something called long-term potentiation. That's how we learn anything in the brain, whether you want to learn a language, whether you want to learn math, or whether you want to learn a behavior like keeping your butt alive in Iraq. And so that hypervigilance, that's very adaptive in a combat zone. That ability to stay awake, that ability to know what's around you, that ability to recognize your 5 and 15 meter blast radius, that's very useful in Bakuba, and keeps you alive for 14 months. But when you come back and you've got a wife and credit cards and a job, and you got to drive in between the yellow lines, those traits that you learned, that long-term potentiation that kept you alive, is now causing havoc in your life. It's maladaptive because now you're that emotional numbness that you learned, that hypervigilance that you learned, is not working out well in the marriage. And so that's effectively how behaviors like PTS get inured, get ingrained. They are literally, by the textbook definition, learned behaviors.
And it's nothing that the person did wrong. Like, does, as you said, it's just like and it could be just like an athlete that's like a pitcher, and they've had to pitch 9 innings straight for 3 months, and now their shoulder hurts, right?
Yeah,
And
that's
it's
exactly
this
it.
kind of the same thing. It's not the soul of the person. It's just this muscle, brain muscle, that needs some help, needs some love. And
Scott, you nailed it, and that's a big message that we want to get out. That we had a force recon Marine who came in, and it's probably one of the more significant stories. This guy had been over in combat. Then he'd had a bunch of experiences, and you're talking about what banged him up. He discovered his father when his father had committed suicide. So that's a very difficult learned experience. He had been a police officer, and he had to draw his weapon and shoot somebody because of their threatening lives. That's also a very difficult experience. So you can imagine this person had a couple of difficult life experiences, and he came in for treatment. And when we showed him at the end the difference before and after on his brain, he said, "I knew it wasn't me. I knew it wasn't me." And he broke down crying in the chair. He said, "You guys fixed it. I knew there was a problem, and you guys fixed it." And that's what's so exciting about what we're doing and why we want to scale this out. We want, first of all, those veterans, the 18 to 22, today, 18 to 22, vets are going to take themselves out. And my guess is they think they're the problem. And that's what we want to get that story out, Scott. They're not the problem. It's like having a broken arm. You got to go get it fixed, right? You got to go get it fixed. You're not the problem when you have a broken arm. All of us know that. But the brain is the most complex organ we have. And there's a lot of confusion on this subject, and it leads to folks taking themselves out, and their cockpits are getting hijacked. And we want to get the message out and get these doors breached so we can free our peeps.
yeah, is there some sort of a maintenance mode as well? So the gentleman that you mentioned, that his PHQ-9 went from 25 out of 27 to 6. Will it kind of stay at that level over time, or what do you kind of see, like, hey, this is something that somebody should
Yeah,
um
that's a very
yeah.
open question in the field. It's something called durability of effect. And right now, the best longitudinal studies have looked back at a lot of TMS and kind of crunched the numbers. The consensus is that it's a roughly 50-50 of who's one and done and who needs to come back. And what I've seen personally is that typically correlates to trauma severity. So, if it's, a few depressive episodes when you were younger and we caught it early and we're managing it well, then I'm pretty confident that one series of TMS is going to address it completely. But if you are a forced recon Marine with 3 tours in Iraq and Afghanistan and line of duty issues as a law enforcement officer, then it is likely going to be a more complex approach to achieving a resolution there. So the real question there is just like any medical question. You have to determine severity at onset, and you have to measure and consistently measure. So the idea here is, yeah, we did our series. Now it's not just, let me shake your hand, good luck to you. It's maintaining that monitoring, that every so often we'll send you that another questionnaire to check in how you're doing. Every so often we'll get that EEG to make sure that the connectivity is staying where I want it to stay. And if it's not, let's catch it early and intervene.
It's kind of like stages of cancer, right? Stage 1, we all know, is really soft. Stage 4 is really hard, right, and strong. And so, like if you break your arm, was it a compound fracture, right, where the bone's popping out? So how bad was the organ damaged? That plays a role in the treatment. And that's where I think the idea of measuring is so important, right? Because right now, the current FDA protocol, the one that was 18 years ago, and thank goodness for this, we're just wanting to improve on it and make it even better, right? But it's that standard protocol. It just identified one location right above the eyebrow, and that's where you target. Well, that's what the study showed, that was at 50% were one and done after a year on durability of effect. We're pretty confident that due to the personalization that we're doing, the precision targeting at TMS, our outcomes and that durability of effect is going to be much better. And we're doing this surveillance. So a guy like Brent Bourne, we're going to send him a survey at PHQ-9 every month. And if it goes from, and while I told you he got to a 6, when he came back, he had 3 more treatments, it got down to a 3. So we expect it to be at a 3 or 4, and to maintain that. And if it ever starts creeping up, guess what? We've got an early indicator. Use the survey, come back in, then we can do the EEG, push it in, put all that data into Halo, and visualize what's going on and see, okay, hey, look, here's another area that needs some treatment, right? Just like you'd go get an X-ray for a broken arm. Let's see what's going on.
Do you think that this is something that should be a part of, everybody should at least get a screening? I mean, we go to the dermatologist, right? And it's like, hey, do you have any signs of skin cancer? I feel like a lot of people have some level of depression, I'd imagine, or something. I mean, if you've lived 30 or 40 or 50 or 60 or however many years, right? Like you've gone through stuff. And is this something that, that should be monitored and hey, maybe once a year, once every couple of years, you go in
absolutely.
and you check your brain health.
Healthcare. You're absolutely right. And this is healthcare. It evolves, right? The standard of care 100 years ago versus today for even a broken arm is different. And so that's what our goal is. Our vision is to increase the standard of care and ultimately increase the outcomes. And when you can catch stuff early, absolutely. I mean, we're at our clinic here in DFW. We encourage that so much. It's $100 to come in and do a EEG and push that data into Halo to see what's going on with your neuroconnectivity. We make it
$100.
$100. It's easy. And then you can decide if you want to pursue treatment, and that could be any treatment. If you want, you may have heard of some of these documentaries where the SEALs went down to Mexico and they're doing Ibogaine. Well, great, but let's create a baseline first. Let's measure the organ, and then after your treatment, let's not ask you how you feel. Let's go ahead and measure the organ again and see how it's working.
Yeah, and one of the best metaphors for that that I use frequently is cardiology. If you had a problem with your heart and you go see the heart doc, they don't give you a questionnaire that asks, do you feel fat, or stares hard for you. They get out a stethoscope and a blood pressure cuff and an EKG, and they measure the organ. And that's just a very simple concept that we're trying to bring into mental health. Just measure the organ. and that gives you longitudinal data that helps you track what those health trends are showing over time.
And Scott, it's just early. So what we'll be doing here is eventually we're going to have funds to do a clinical study, and then we're going to have the evidence that'll show the impact that this precision TMS is having on folks. Right now, anecdotally, we're seeing incredible outcomes, and folks like Brent going into remission. Remission. He came off one of his antidepressants. I think he's weaning off his other one. Right. I mean, we're fixing the organ, so you don't need to saturate it with a pharmaceutical. And hopefully we're able to even get studies down the road where it's not just TMS, it's in combination with a pharmaceutical, right? We're learning so much about the brain, and how do we deliver good outcomes. And usually it'll be multimodal. We see that in so many other health diseases. It's not just one solution, it's several that are coming to play.
So what is I guess, so let's say that somebody listens to this podcast and they're like, hey, I live in Dallas, or hey, I'm going to fly in and take Bret and Russ up on their offer. Like, I want to see what my brain kind of looks like. Maybe I don't know maybe they're struggling with something. Maybe they're just interested in optimal performance. And, so they go through the screening and, pay $100 or whatever it costs. And you see, I guess maybe some colors right up on the image, and you're like, hey, like there seems to be a little bit of an issue here. What does that process look like for them to go through the TMS?
Great question, Scott. The first step is go to our website, classic clinic operation, compassion-neurohealth.com, and you're going to sign up for a complimentary pre-screening. So you'll be talking with folks on our team. They're going to ask you a bunch of questions, from your name, phone, address, email to what's going on, what's your history, what's your medical history. Okay, sounds like you're a candidate. And then they'll schedule you for a Halo. That's where you come in, you do the EEG, and then that data goes into Halo. And now you're going to be able to visualize the dysregulated networks. Once you see that, if you're compelled and you want to go see our psychiatrist, then we set you up for an appointment with our psychiatrist. That's a 30-minute consult where, again, the determination is made, is TMS going to work? So our software Halo is considered clinical decision support software. It's a category the FDA has for this stuff. And so that software is going to enable our doctor, Dr. Kromenacher. He's also an Air Force vet. Dr. Kromenacher will take a look at that data. He'll hear your story. He will apply his psychiatric medical experience and most likely prescribe a treatment regimen. In this case, it would probably be TMS, the precision TMS. Then there's a choice that the patient has of either using a self-pay solution or an insurance solution. If it's insurance, we're going to submit a prior authorization, just like you would do for a knee surgery or knee treatment. And then we're going to get that back from the insurance company. And then you would come in for your course of treatment. The standard insurance protocol today is you come in for 15 minutes, 5 days a week for 6 weeks. So a lot of folks flying in for a Brent Bourne, he's like, hey, I'm not doing that. I live in Colorado. Do you have an accelerated protocol, which we do, where we basically take 3 of those treatments and do them in an hour? And so we'll do an hour for 10 days. So in both of those treatment protocols, both the 15 minutes, 5 days a week for 6 weeks and the hour a day for 10 days, we do the Halo at the beginning, the midpoint, and at the end, right? So we do an EEG, put the data into Halo, and we look at what's going on. So at the midpoint, as Russ had mentioned earlier, is it working? Are we targeting the right targets, and is it having the right impact? And at the end, you're going to see the changes in those dysregulated networks, right? The improvement that was made in them. And then we're going to put you on the monthly surveys where we're just going to send you a PHQ-9 and you're able to monitor yourself, right? And if you want to escalate and come back because you need more treatment, you need more rehab, great. Then you can come on back.
Wow. And the results or the outcomes that you described earlier, kind of going back to those, like, hey, I'm sleeping better. I've never slept like this. I can't remember the last time I slept like this. And the negative thoughts, the ruminating thoughts are gone. Seems to be, a really great benefit. Is there any like, what's the reason why somebody wouldn't do this? Like, is there any risk? Is there any like negative side effects
No, the,
from
the
the
risks are
TMS?
exceedingly minimal. The only hard contraindication is metal in the head, and usually the only time that could really happen is if you had aneurysm clips or some surgical intervention in there. But even hearing aids or cochlear implants typically are fine. Dental stuff is fine. It's FDA cleared for use in children 15 years and up. It's FDA cleared for use in pregnant women. The safety studies show no effect on mother and child, which is another area that I care deeply about in postpartum is not putting fluoxetine in the breast milk as a step one intervention. So if you're FDA cleared in children and pregnant women, that's effectively the same risk profile as aspirin.
All right. Well, thanks, guys. Congrats on building this. And, I just, with all of just being the awareness that people have now, or, just that they get through like wearables and like, hey, I can see how much REM sleep I got last night, or how much
Right.
deep sleep, and, what my HRV was. And it just seems like this would be just another really great metric to be just aware of, like, hey,
Right.
like, how is my brain health, and at least get
Scott,
measured.
100%. I mean, think about our guys right now that remarkably are over in Iran, or we know from folks that have been on mortar teams. I mean, that concussion effect, let's see, what is it doing? And we could really easily deploy this out in the field with an EEG and do halo and go, look, you're good to go. Or, hey, you know what? You're not good to go. We need to rest that organ and treat it. Here you're seeing the results. Let's be aware of that. And so just the ability to measure, just like you said, with the wearables, it's the same thing here, Scott. We're able to measure that very, very complex organ and then determine, and the patient gets to choose, do you want to treat this or not? Right?
Yeah, yeah. Well, awesome, guys. Well, we just we kicked off Q2 here recently. So, as you guys look out over the course of this quarter and this year, what are some of your maybe short-term goals, and then also, what's kind of like your moonshot goal? If you look out over the horizon, 3, 4, 5, I don't know, 10 years from now, like where do you see this going? Where would you like it to go? And then just a follow up to that, where are you stuck? What connections are valuable to you? What help do you need from the folks that are listening today?
Well, short term, I think we're pretty excited because we're almost at capacity with our first chair. And our business model, Scott, has two elements to it. It's one, the clinic where we're treating patients with TMS, right? We're billing insurance or doing a self-pay. But the second part is Halo, and that software as a service, and being able to license that to other TMS clinics so they can have similar outcomes. That's another big opportunity for us. So we want to really knock a dent. It wouldn't be amazing if that number, the 18 to 22, got down to 1 or 2 a day or less, maybe it's 1 or 2 a year, because we've revolutionized the treatment. We're bringing neuroscience into psychiatry. So now this is interventional psychiatry. There's an intervention that's going on. That phrase is one of my favorites, and I got it from our psychiatrist. That's how he defines himself, as an interventional psychiatrist. And so short term, we're upgrading our facilities. We're going to have a couple of chairs here in DFW. Then we're going to be learning along the way. What does it look like for access? So even if the treatment protocol got down to 10 days, you can't drive 5 hours for 10 days in a row. You can probably drive 20 minutes 10 days in a row. Where's the difference there? So where do we need to be putting these clinics around DFW or around the country? And/or can we be licensing our software to help out the existing clinics that are out there? There's about 1,000 clinics in the country right now, but they're not seeing those incredible outcomes because they're not measuring, right, and personalizing the treatment for the patient. I think that hits kind of the goals of what we want to be doing here clinical-wise. If we got up to 15, 20 clinics in the next 5 years, that'd be amazing. But we're going to learn, Scott. We don't know if do we have one clinic here with 10 rooms that people are flying into DFW for? or do we have 5 clinics across DFW and 50 across the country? We just had a call yesterday with a classmate. There are 30,000 veterans getting out of the military a year that have been diagnosed with depression using the PHQ-9. We'd love to help them, but 30,000. I mean, that's a lot. Not only that, but what about the general population and taking care of them? Russ, what are you thinking?
Yeah, the key things for us is remembering where we came from, taking care of our tribe, taking care of our guys. I mean, we were leaders of soldiers, and that's going to stay with us for life. We still are leaders of soldiers. We're responsible for these guys that trusted us, and we also are always going to be there for our Gold Star families, where it's a key focus of ours to make sure that those families get the absolute best treatment possible. That if anyone's going to get it, it's going to be them.
All right. And what connections are most valuable to you guys?
That's a great question. So we're starting to leverage our networks, but getting connected with folks that are in the military, health related in the military, healthcare related, to explore how do we get this out to folks that are out in the field, right? So they could easily do this diagnostic solution and evaluate somebody. Are they fit to go back into combat or not? Along with folks that are like-minded from a venture standpoint. Obviously, funding would allow us to accelerate our growth, to turn Halo into software as a service. So a clinic in San Francisco could license the software. They could do the EEG. They could put it in and now personalize their treatment. Or is it the clinic that's been set up over in UAE to take care of some of our guys that have been in Iran? So those are the things that we're thinking about. I do want to make sure I call out as well a charity that we established, Scott, and it's called Heroes in Mind. And Heroes in Mind is raising awareness and funding for those that can't afford this treatment. So think about a Gold Star family. Think about a Gold Star family member. The VA takes care of the soldier, and it'll take care of a spouse and down with the kids. But they're really not. They weren't set up to take care of mom and dad, right? And that's not their mission, and that's okay. But we want to take care of those Gold Star families that have made the most incredible sacrifice. Heroes of Mind is doing that. So if somebody felt so inclined, they can make a contribution to Heroes of Mind. And we have a very unprofitable agreement with Heroes of Mind where we will treat those folks at cost. And that's an agreement that we're going to have for a long, long time.
All right. And what's the best way for folks to reach out and learn more about what you do and get in touch with you guys?
It's probably go to our website. So it's going to Compassion Neurohealth. We're both on LinkedIn as well. You can find us there. But Compassion Neurohealth is where a patient can reach out or somebody can contact us if they want to help out with our growth plans.
All right. Well, sounds good, gents. And we'll link to your website and LinkedIn profiles in the show notes so people can easily connect with you after they listen to this. And hey, thanks for being a guest on the podcast. And thank you again, it's been great watching your presentations to the investor group over the last few months. And here's to an awesome 2026.
Excellent. Thank you, Scott. We appreciate you getting the word out on all this good stuff that's going on.
Definitely.